Welcome to the third webinar in the Navigating Dementia series. We're excited to tell you that we've had a fabulous response. Over 600 of you registered for today, which really underscores the important work we are all doing to support everyone who's facing these neurocognitive challenges. I'm Laura Gillen, a gerontologist, educator, and care partner who's a project consultant on this series. So Navigating Dementia is a 5-webinar, 2 in-person conferences about Alzheimer's disease and related dementias. This was developed for a diverse audience of care team members, loved ones, paid caregivers, employees of Maryland Agencies on Aging and Maryland Access Points, and the range of aging services providers. This spring 2024 series is funded by a generous grant from the Maryland Department of Aging, whose vision it is to change the trajectory of aging. The series has been designed and made possible by the efforts of the talented members of the Geriatrics and Gerontology Education and Research Program grant team at the University of Maryland, Baltimore. G-Gear is a program that facilitates interprofessional education and interdisciplinary research activities in the field of aging in partnership with campus affiliates and agencies and organizations, all serving Maryland's older adults and their caregivers. So this series was created with the following objectives: to advance your personal understanding of dementia, to formulate realistic expectations based on the effects of dementia on persons living with ADRD and their caregivers, to demonstrate confidence in interactions, which reflects evidence-based, unbiased, culturally sensitive approaches to care, and to create meaningful living opportunities for adults living with dementia in Maryland. A few housekeeping items. The only way that we know you are attending is if you are using your own personal link that was mailed to you. And we can only issue CEUs if you have been registered and are using this link. So if you have any questions right now about that, you can put that in the Q&A box. So at this time, please be sure you've completed the pre-survey questions using the unique participant ID code that was listed on your Zoom invitation. This is the same link for each webinar in the series. So if you have a previous ID, you can use it again. A link to that pre-survey is available in the Q&A box now, and it's available in the Zoom meeting email that you received yesterday too. So the Q&A box is the place where you can drop in anytime to type in a question during the webinar or place a comment. The presenter will address your question before the webinar concludes, and we will address questions at the end of the presentation. If you're here today, you must be present for the entire session if you would like continuing education credits. And due to the large number of participants, it will be probably a few weeks before your CEU certificate will be emailed to you. So there will also be a post-event survey and evaluation at the end of the webinar, and we will allot time for completing these after the second presenter concludes her remarks. Closed captioning has been enabled. Just click the closed captioning CC button at the bottom of your screen. If you don't see it right now, just hover your cursor near the bottom of the screen and it will appear. Everyone's audio and video has been muted for the webinar. So here's webinar 3. The title is Exploring Medical and Non-Medical Interventions to Improve Cognition, Well-Being, and/or Slow Cognitive Decline Associated with ADRD. So the objectives for today are to learn about some evidence-based non-drug strategies which improve cognition, well-being, and/or slow cognitive decline, as well as more details about any pharmacological-based options currently in use. Second is to describe the benefits and limits of these interventions for both the person and care partners, and the timing of when an intervention is best offered. Thirdly, to understand the broader societal impact of interventions in terms of measures of well-being, usefulness, and costs. The details and learning objectives for today's webinar are available in the program book that was emailed to you. Please take a moment now to open it. There are many resources in the book that will be useful to you. Now it is my honor to introduce to you our presenter. James Richardson, MD, MPH, was Chief of Geriatric Medicine at Ascension St. Agnes Hospital in Baltimore from about 2008 until 2023. His professional interests include inpatient and outpatient geriatric medicine consultation for older adults with problems such as memory loss, dementia, frailty, weight loss, falls, depression, and health promotion. He's a graduate of the University of Maryland, Baltimore County, and the University of Maryland School of Medicine, a true terrapin. Dr. Richardson completed a residency in family medicine at the University of Maryland. So there was a 2-year commitment in North Carolina at the National Health Service Corps, after which he joined the faculty at the University of Maryland School of Medicine, rising to the rank of professor, where he's an adjunct in family medicine currently at the university. He also completed a Master of Public Health degree at Johns Hopkins University School of Hygiene and Public Health in 1995. He left the university to serve as Chief of Geriatric Medicine at Good Samaritan Hospital and Union Memorial Hospital before joining St. Agnes Hospital in 2008. He's published more than 65 peer-reviewed articles and book chapters, and has lectured widely to both professional and lay audiences on topics such as geriatric medicine, memory loss, infections, falls, and delirium. He's board certified in family medicine, geriatric medicine, hospice and palliative medicine, and general preventive medicine. And so now, without further ado, I'd love to introduce to you, it's my honor to introduce to you Dr. Richardson. Thank you.
Well, thank you. That was, oh boy, pretty much used up all my time. So no, that was very nice. Thank you, Ms. Gillen. And thank you, Dr. Martin, for allowing me to participate in this topic, which is near and dear to my heart. As you heard, most of my career, I've been helping families and their loved ones with dementia navigate this horrible disease and help them. And so I'm very pleased to be part of this webinar. You may notice that I have a scratchy voice. I haven't had a cold in a really long time, but I got one just in time for this. So please excuse my voice, and I will try do my best to speak up so that you can hear me okay. All right, let's get started. Let's see. I'm having trouble advancing the slides. Oh, there we go. All right, I like to include this aphorism from Mark Twain. It's so important, I think, to all of us who work in the healthcare field, or actually any professional field. It's not what people don't know that hurts them, it's what they know that ain't so. And if you think about it, that's very true, that if we forge ahead and act without thinking, when we think we know what's right, that's when we get into trouble. It's important that we find out what is the best answer before we act. And I think that's especially true in this area of dealing with older adults with memory impairment and dementia. There's a lot of misinformation out there, and we want to make sure we're using the latest information. Okay, now you're wondering why I am showing you a Brachiosaurus at the Museum of Natural Science in Houston. Well, that's because this field, like this gentleman in the teal polo shirt, this area is so broad that he was daunted by the size of this dinosaur. Well, I was daunted by the amount of information that we have about treating people with dementia and with non-pharmacologic interventions. But we're going to soldier on and do the best we can. I do want to mention there is tremendous additional information in the resource book, which you've all been given, and goes into much more detail than I can squeeze into my brief talk. So please avail yourself of that resource. Okay, my objectives for today. Let's see, I'm trying to change the screen here. Okay. My objectives for today, pardon me, one more thing, if I can. I'm trying to, oh, there we go. There we go. Sorry about that. My objectives are I'm going to briefly review the presentation of people with Alzheimer's disease and related dementias because so many people have signed up for this webinar. I'm sure that many of you attending were unable to obtain earlier, to be part of the earlier webinars. So I thought just a very brief review of dementia would be helpful. Then I'm going to talk about non-pharmacologic interventions to manage both behavior and hopefully to slow decline. I'll throw in some do's and don'ts, and then at the very end, throw in the most frequent question I'm asked by family members. I'm sure many of you are familiar with the Maryland plan to address Alzheimer's disease and related dementias. There's the link. If you want to go online and read it, I highly recommend it. It's also listed in the resource book, but I've listed 3 of the most important conclusions. First of all, Alzheimer's disease and related dementias are common, and we're going to see more people with these diseases. Importantly, these are underdetected and underdiagnosed, and that's been, I found to be true throughout my career, unfortunately. Also, we do have effective symptom treatment options, but we also know that many families have care needs that are unmet, and many of these are non-medical. So let's talk a little bit about dementia. I'm often asked, what's the difference between dementia and Alzheimer's disease? Well, think of dementia as the umbrella term for all the diseases that can cause cognitive decline in adulthood. And there are many, many, many that do. Vascular probably being the most common after Alzheimer's, such as occurs when someone suffers a stroke. Then there's dementia with Lewy body disease, which is a kind of combination of Parkinsonism and dementia or Alzheimer's. Then after that, you might, in prevalence, you might find frontotemporal dementia, which by report is what the actor Bruce Willis is suffering from. And Parkinson's disease also has a form of, can develop into a form of dementia. And then there are many other less common entities and etiologies, including some infectious causes and endocrinologic problems such as hypothyroidism or vitamin deficiency. But Alzheimer's disease is by far the most common of the causes of dementia. And that's why I think sometimes Alzheimer's and dementia are used interchangeably. However, since the treatment may vary depending on the etiology, it's important to try to distinguish the etiology when possible. To meet criteria for Alzheimer's disease, at least 2 areas of cognition are impaired, almost always memory loss, along with another. And if you think about it, we use our brains for a lot more than just memory. We use them for language, for planning, which is sometimes called executive function, for judgment, for visual spatial. So in cases of Alzheimer's disease, usually at least one, if not more than one, other area is involved. And of course, to meet criteria, it must be a decline from the previous level of function and impaired daily activities, whether that be work or social. This is a photograph of Dr. Alzheimer and his first patient, Frau Dieter. He was able to take care of Frau Dieter in life. And then when she ultimately died from the disease, he studied her pathologically and described the neurofibrillary tangles and plaques that we now know are the hallmarks of this disease. So when I talk about Alzheimer's, I like to pose this question. What is the problem with Alzheimer's disease? Well, obviously, there are a lot of problems with Alzheimer's disease, but the real problem from my perspective as a healthcare provider is that we're not diagnosing it. Several years ago, the Alzheimer's Association put out a special report. They estimated that as many as 50% of people who meet criteria for a diagnosis of dementia have not received a diagnosis, have never received a diagnosis. That's just really unfortunate, to say the least. And unfortunately, it does mirror my own experience that often by the time someone's been referred to me for a diagnosis, it's clear they've had a diagnosis of Alzheimer's disease for years in many cases. Interestingly, the corresponding figure for HIV, people living with HIV, is only 20%. Only 20% of them have not been diagnosed. This has been, as I said, my experience as a geriatrician for many years, and I blogged about it many years ago on kevinmd.com. If anyone would like to read more about my concerns about this. As healthcare providers, we need to do a better job. Okay, well, why is it important to diagnose? You do occasionally run into physicians who don't seem to be very concerned about making a diagnosis. I think it's less common now than earlier in my career, but you used to hear comments like, well, you can't do anything about it, so why make the diagnosis? Well, it's important because we need to think of this disease or in all dementias as treatable, not maybe curable, but at least treatable. By making a diagnosis, we can help patients and families understand the patient's behavior. We can help manage their other conditions. If someone has dementia and that has not been diagnosed, they probably aren't going to manage their own hypertension or diabetes very well. And unfortunately, since dementias are almost always progressive, long-range planning needs to occur as early as possible in the process. And if we don't make a diagnosis, we can't start the planning. I always like to mention the Alzheimer's Association Know the 10 Signs questionnaire, because I think this is a good starting place for families who have a family member that they're concerned about, but they're not sure where to start or if the problem is really a significant one or not. The great thing about this questionnaire is it not only addresses particular problems, possible problems, but it tells you what might be normal and what is not anything to worry about. The questionnaire looks at 10 areas of cognition, and most people, even with definite dementia, do not have areas in all 10 domains. But if they have problems in 3 or 4, they really should have an evaluation to see if they are suffering from a dementing illness. And you can see the list here, and of course it's on the Alzheimer's Association website. So I'm not going to dwell on it in the interest of time. But remember, it's more than just memory loss. Problem solving trouble, getting confused in a location, having difficulty understanding an image, losing things. You can see the changes that can be problematic. So if you're not familiar with the Know the 10 Signs, I recommend you take a look at it. It's very helpful in helping families get started in a way to get them evaluated. Okay, now let's talk about behavior. We'll be, in the rest of my talk, we'll be discussing interventions for both behavior and cognition. As you might guess or know already, there's considerable overlap. In other words, interventions that help with behavior, especially problematic behavior, may also have cognitive benefits and vice versa. But first, we'll start with behavior. I do want to start with a caveat, and that is that if a patient with dementia is exhibiting an abrupt change in their behavior, we have to be concerned about the possibility of delirium. So I say, remember your ABCDs. Always be considering delirium. But what is delirium? Delirium is an alteration of consciousness with impaired attention. It usually develops over a pretty short period of time, maybe as short as a few hours to several hours. And the level of consciousness can fluctuate. Patients who are delirious exhibit disorganized thinking. They may think they need to go to work when they have been retired for 20 years. They may be very somnolent and hypoactive, or they may be hyperactive and trying to run out of the home. Other terms for delirium are altered mental status, but the preferred term these days is delirium. Now, why am I dwelling on this? Well, this could be a true emergency. If a person is delirious, you need to figure out what the cause is. A severe infection such as pneumonia or renal failure, liver failure, other metabolic changes such as a very low sodium can cause delirium. Often there's more than one cause. And unfortunately, sometimes prescription drugs may be given by a physician who is not managing the patient's dementia can be a precipitant. So again, delirium is not going to be that common, but I felt the need to mention it because if it does occur, it's a medical emergency. Okay, before we address specific behaviors, I think there's some rules of thumb for working with persons with ADRD that the Alzheimer's Association summarizes on their website. And I'm going to ask again that if you're not already familiar with the Alzheimer's Association website, it is truly a wonderful resource. These particular guidelines are called hints for home. The reason this is important with behavior is if they have a family who is working with a loved one with dementia, having these hints in place, trying to adhere to them, will help avoid more problematic behaviors at a later time. And the other point I'd like to make about this is all these are not geared specifically to improve cognition. By keeping the person involved and part of the family and working with other members of the family, that most likely has some will cause some improvement in cognition as well, or at least halt its decline somewhat. So involving the loved one in activities around the home. such as cooking or cleaning, of course, keeping in mind safety. A person who previously worked in an office may love to spend some time handling paperwork. It's important not to argue with the patient or correct the person. If they are happy and not upset, and they are saying something that's clearly not true but not upsetting them, it doesn't help to try to correct them because they are unable to make new memories in most cases. When it comes to daily routines, allow the individual to make their own choices to the extent they can. They may have trouble with doing certain activities, and you may have to help them start an activity. If you give them a complicated direction, they may not be able to comply, or they may even become upset. But if you simplify the instructions, that can help them. Also, it's important to be flexible. And also, if the patient or person is getting upset, it's important to acknowledge that and to reassure them that you are looking out for them. There are neuropsychiatric symptoms, however, that will come up from time to time in many patients. And these are the behaviors, this is a partial list of the behaviors that families have asked me to address because they are worrisome to them. Obviously, persons who start hitting or become angry, that can be quite alarming to families. Persons who get up in the middle of the night because they think it's morning time. Some persons with dementia just become generally anxious, and they keep worrying that something bad is going to happen, where they become paranoid. Then there are some that are just impatient, and no matter what is happening, they seem to believe that something else should be going on, and they need to be moving on to some other activity. Conversely, some persons with dementia will just be very apathetic and not do much during the day except sleep. When it comes to problematic behaviors that are concerning the families, I think we can think of these as having both predisposing factors and precipitating factors. Predisposing factors can make the behavior more likely to occur. So, for example, an over or understimulating environment. If the environment is very stimulating, such as taking a family member with dementia to a large family gathering, they may become very upset because they have difficulty understanding everything that's going on around them. An understimulating environment can also cause the individual to become upset because nothing is going on. It's important to the extent that families can, to address special sense impairments too, such as vision loss or hearing loss. Now, a lot of individuals with dementia will not wear hearing aids, but some will wear glasses, and some will. So to the extent that they will tolerate those, that will help them. In particular, I think if someone with dementia is developing cataracts, cataract surgery is very well tolerated and will help them obviously see better, but also reduce the risk of falls. Then, of course, as we talked about earlier, dementia is a progressive disease. And sometimes a person who's been managing pretty well in their family, with their family members, will become more difficult. Their behavior will become more difficult simply because their dementia has progressed. Lastly, if you're working with a family, we want to be aware of the burden that caregiving can cause, and acknowledge that and do what we can to address the burden and help that family. Those are predisposing factors. Precipitating factors tend to be more immediate, such as pain, hunger, thirst, needing to go to the bathroom, being cold. Cognitively impaired individuals may have great difficulty expressing themselves and their needs, and this may cause them to become very upset. A few years ago, I was seeing a patient, or asked to see a patient, who was in the hospital and was becoming very agitated. I was paged and asked by his nurse to give him a sedative. I hadn't seen the patient, so of course I went to see the patient. And when I examined him, I discovered that his bladder was extremely distended. And that's why he was very agitated. Once we relieved the distension by placing a catheter, he was no longer agitated and he did not require any medication. Also, again, I'm going to go back to medications. A medication can be a precipitating factor. And my favorite geriatric medicine aphorism, as you see there, is whenever there's a new problem, first look at the medicines. If you're seeing an individual with a problematic behavior and you've excluded delirium, which we've already talked about, then the best, the approach I recommend is to decide which behavior to address. Trying to address more than one behavior at once is not generally helpful or productive, but you decide on a behavior, adjust the environment as needed, such as increasing or decreasing stimulation, giving them glasses or hearing aids if they need them and if they use them, and also monitoring the patient's needs, making sure they're not hungry, thirsty, the room's a good temperature, they don't need to use the restroom. And then you want to monitor the response. And then you start with your intervention. What did you try? Was it distraction? Was it touch, reassurance? And monitor their response. Which intervention worked? Which time of day was best to intervene? Flexibility is also very important, as I mentioned earlier. It's important to monitor your own response when you're working with the individual with impairment. Patients, cognitively impaired individuals may notice that you are becoming upset working with them, and that in turn makes them even more upset. And then you want to decide what worked, what didn't, and how to plan for the next time this comes up. Were there any warning signs that you might have missed the first time? Some general rules of thumb, and I'm sure many of you in the audience already know these, but for some maybe haven't given this a whole lot of thought. You don't want to disagree with the individual even if you know they're wrong. You want to speak slowly, calmly, maintain eye contact with them. When you can, redirect them to an enjoyable activity. And it's also important to acknowledge their concerns and to reassure them. And as I mentioned earlier, allow them to make choices. An open-ended request like, do you want to get dressed now, is not as likely to be as helpful as giving them a choice between two items that you wish them to do. All right, now I'd like to talk a little bit about some specific behaviors. Insomnia is a big problem many times if a loved one with cognitive impairments living with younger family members who are still working, it can be very difficult if they're getting up every morning at 3 a.m. because they think it's time to go to work. I do find, if at all possible, that exposing these folks to natural light is very helpful, especially these days, although today is cloudy. We're now getting to the time of year when we have much longer days, and exposing folks to natural light helps reset the circadian rhythm. Also, avoiding caffeine, of course, and avoiding liquids after dinner is helpful. What about delusions? Delusions are often upsetting the family members, but if they're not bothering the person with dementia, it's not anything that needs to be addressed. I had a patient who used to routinely talk about talking to his father. He would come down in the morning and tell his family, "Oh, I just talked to my father." Well, his father had been gone for many, many years, but he was reassured by these discussions, and obviously his family learned not to try to tell him that his father had passed away. On the other hand, if the delusions are upsetting, we do want to reassure the individual and let them know that you'll take care of them, you're going to protect them. Touch often helps in these circumstances, and then distracting is also helpful. Anxiety often responds to touch as well. Anger and aggression, that can be more difficult and may mean addressing the environment if it's a particularly noisy environment that may be agitating the individual. Wandering is a specific problem for some people, and I highly recommend the Medic Alert program that the Alzheimer's Association has, so that these individuals are kept safe. Let's see. Okay. I just throw in one more thing about wandering. Sometimes families want to put in place barriers in their homes to make it difficult for the loved one with dementia to leave, but you have to be very careful that nothing is put in place that would keep them or anyone else in the home from leaving in the event of a true emergency like a fire. So we have to be careful that we don't set up a dangerous situation. Okay. Some do's and don'ts. And we've pretty much reviewed these approaches. You want to be patient, take your time. I think it's important that, and this is an area of research that is constantly being updated. So we in the healthcare field who work with these families and individuals need to keep educating ourselves about the best approaches. And we also want to educate our families so that we are using the most up-to-date approach. I said, don't immediately ask for a sedative, because I've had patients referred to me who somehow or other have been given the idea by their referring provider that the treatment for any kind of behavior problem is a drug, and they haven't tried any of the non-pharmacologic approaches. As you'll hear, sometimes medication is necessary, and I have treated many people with medications when it's appropriate, but it shouldn't be the first step. Over-the-counter medicines like Benadryl are not usually very good for these individuals, and they should not be given without consulting a prescriber. Also, we don't want to neglect the other health problems that these individuals may have. Do they need dental care? Are they still seeing their primary care provider to make sure their hypertension is managed or their diabetes is being managed? Now I want to talk a little bit about cognitive decline. As I mentioned earlier, anything that helps, I think, with behavior can help with cognition and help preserve cognition. But there are interventions specifically geared to maintaining or improving cognitive reserve. This is an area of tremendous research, and the resource book has much more information in it than I can get to right now. I highly recommend you look to it, I should say, um, to learn more. In general, in general, you can say that most cognitive interventions seem to have at least a modest benefit, but a lot of the studies are fairly short duration. So it's hard to know if these improvements are lasting. So briefly, there's cognitive training, which is formal training of cognition. There's cognitive stimulation, often done in a group activity, such as discussing current affairs. Massage and touch therapy, usually well accepted, but it's important to note that some people will not like that and will resist it. Music therapy does seem to help with mood, with depression, but there's not much evidence that it helps with cognition. Exercise is always a good idea, but again, it's not clear that it helps a lot with cognition. So we do want our persons with dementia to be active to the extent they can. Reminiscence therapy, such as looking at an old photo album, seems to have some effect on both mood and cognition. And social interaction almost always has some benefit, but again, it's unclear how long lasting. It's important to point out for some of these interventions that they're not always easy to put in place. They may require a specialist to help the individual or specialized training for the caregiver for the demented person. Okay, so once I've met with a family and talked to them about the care of their loved one and have developed a plan, the question I always get is this: what can I do to reduce my risk of developing dementia? So I thought I would say just a few words about that before we wind up. So how do we reduce the risk of dementia or delay its onset? Well, why am I showing you a heart? I'm showing you a heart because it's very, very clear now that anything that is good for your heart is good for your brain. And we know what those are because we've been hearing these from our doctors and nurses and other healthcare providers for years. And this is especially true, and this all should start in middle age, if not earlier, because the later you start, the less likely, the less impact it will have. So not smoking, maintaining a healthy weight, exercise, and that doesn't mean training for the Boston Marathon, but simply moving, eating a healthy diet, having little or no alcohol, monitoring blood sugar if someone is diabetic, or blood pressure if they're hypertensive. One thing that's on this list, which is not related to heart, is hearing loss. There's more and more evidence that hearing loss, especially if it develops in middle age and is left unattended, is a risk factor for dementia. Okay, so let me summarize. We want to confirm a diagnosis in people with memory loss and get them into treatment. Establishing a routine is important, but there is a need to be flexible. Correcting predisposing factors such as eyeglasses helps with behavior, and avoiding precipitating factors such as making sure the patient's not cold or hot or thirsty or needs to use the bathroom. And then a systematic approach is very important when it comes to managing behaviors. Medications may be needed for some behaviors, but I ask my families to resist the urge to try over-the-counter medicines, or these days even cannabinoids, before consulting their provider. As far as cognition, many interventions do seem to have at least a modest benefit, as discussed in the resource book, but the duration is unclear. I always like to recommend a 36-hour day. Now in its 7th edition, I have a 3rd edition, which I've used over the years. It's a wonderful book Nancy Mason, Peter Ravens put together, and a great resource. It doesn't have to be read cover to cover. You can read the sections that are appropriate. Here's some resources in addition to ones that are already in your resource book. And I think that's it. I thank you all for your attention, and I look forward to hearing your questions.
Okay, I'm just checking the chat or the Q&A box for you, Dr. Richardson, and someone has a particular question about use of light boxes during the winter to replace or augment natural light. Have you recommended something like a light box?
That's a very good question. And I have not specifically recommended it, but if a family asked me about it, and it could be done safely, in other words, that the individual wouldn't try to do something with the light box, I think it would be worth a try. It's certainly the kind of intervention that I would think had very little downside. So I think that would be worth trying. Unfortunately, I don't know the literature on this off the top of my head. So it might be worth looking into that before purchasing a light box. But at least I would think other than the expense, there'd be very little downside.
Right. Okay, thank you. And then a comment from an attendee was regarding the reminiscence therapy. There are programs like music and memory and time slips, which are something to investigate. So that was a comment. Someone is asking about tinnitus or tinnitus. Is that a factor for Alzheimer's? Do you know?
Yeah, tinnitus is very common, but I've not heard that. I guess the only thing I would add to that is if it's accompanied rather by hearing loss. The hearing loss is definitely turning into a significant factor. It's not clear exactly why it's a risk factor, but the evidence is pretty strong. So anyone who's middle-aged and has experiencing some hearing loss and is putting off getting it looked into, that they should be encouraged, and that might be enough to persuade them to buy something that would help them.
Thank you. Someone asks do you know anything about the connection between a diagnosis of executive functioning disorder? Does a diagnosis like executive functioning disorder predispose you or make you more at risk for developing dementia?
I'm not familiar with that. I guess I would be a little concerned. If someone has that diagnosis, I assume they're under the care of someone knowledgeable about that condition. So I would recommend they continue to follow up with that individual, that provider, and make sure that they do not develop other areas of impaired cognition. But I've not read that is a risk factor in and of itself.
Okay, thank you. And then someone is asking about supporting a person with dementia who is grieving the death of their partner. So what's the best way to support someone who has dementia and is grieving the death of a partner?
Grief is, of course, very difficult for anyone, and especially when there's cognitive impairment. If the individual who passed away was enrolled in hospice, hospices often, well, not often, all do, hospices provide grief counseling. And even though the patient or the person has some cognitive impairment, I would strongly recommend they look into grief counseling. If they were not in, if the individual was not in hospice, they could still pursue grief counseling on their own outside of a hospice. But just the fact that they have some cognitive impairment wouldn't mean that they wouldn't benefit from counseling as well.
Yes, thank you. That's a good suggestion. Someone is asking about photo albums. Do you find them helpful or harmful? That reminiscence through photo albums, helpful or harmful?
That's a very good question. I would think that would, I have not heard of anyone, any of my family saying that they were harmful, but all older people are different, and all people with dementia are different. So I would imagine there are at least the occasional individual that would become upset looking through an old photo album. They might not recognize individuals in their family because they look different in the photos than they do now, or vice versa. So there probably are some people that would be upset, and it would just you just have to, I think, be careful as you explored the therapy with them to see how they responded.
Right. Agree. Okay. Someone has a client whose wife refuses to be evaluated by a neurologist. Any ideas for how to help her to agree to an evaluation?
Yeah, that's very difficult. I've been the provider on the other end of that kind of situation. This is an example of someone with impaired executive function. That they don't think they have a problem, so they don't see why they need to see somebody. I mean, that's what it sounds like. It's very tough. Obviously, if they're in danger, they can be taken to an emergency room. If they're in danger, they might need to be evaluated in an emergency room. But it sounds like in this case, that's not what's going on. If they can get them to a regular provider, say their regular primary care doctor or a nurse practitioner, that person could at least initiate, even if they're not very comfortable making a diagnosis of dementia themselves, they could at least initiate a workup, make sure it's not something unusual, such as hypothyroidism. If they won't go to any provider, that can be really, really tough. I don't have an easy solution. I have sometimes seen patients who have been brought to me against their will, and sometimes they calm down and you can evaluate them, and sometimes they don't. So it is difficult.
I'm going to stop the questions now. Thank you, Dr. Richardson, for your presentation. That was really informative. I know that there are still about 25 questions in the Q&A box. And so what I would ask, if a couple of different things. If you have time and you want to go through the questions and answer them now, you certainly can. Otherwise, we can certainly compile them and send them to you for a more thorough response and get them out to our attendees. But we do need to take a 5-minute break now as we change over to our next presenter.
Okay, I'll be happy to try to answer as many as I can.
Okay, great. Thank you.
Okay. So the next question that you might address is there a connection between traumatic brain injury and susceptibility to dementia that you know of?
Traumatic brain injury and susceptibility to dementia. Yes, I think that's what we're seeing in the NFL players who have CTE. So, I mean, it's like any risk factor. It doesn't mean if someone's had an injury that they're definitely going to get dementia, but I think it's certainly a risk factor and they should be followed.
Thank you.
Okay.
Yeah, if you can just go through the Q&A, Dr. Richardson, if you'd like to type in some responses.
Yeah.
Please.
Okay.
Yeah, thank you. And everyone, we're going to take about a 5-minute break so that you can stretch and get some water, whatever you need. And then we'll come back at 2 o'clock with Dr. Nicole Brandt.
Hi, Dr. Martin. Hi, Dr. Richardson.
Hi.
Gosh, Nikki, you sound like me. I hope you didn't catch this from me.
I don't think I caught it from you. I'm hoping it's just allergies, but
Okay.
yeah, I can't say I'm having the best voice today. I sound like a frog.
I'm sorry. I know what that feels like. I'm so sorry.
No problem. My
Right.
apologies for that, but I will do my best to not sound too much like Kermit and go through the content. Jim, how are you?
I'm well. Boy, I'm having trouble since I left my presentation. I'm having trouble seeing everybody.
Jim, if you could stop your screen share, and then you'll be able to see Nikki better, and then Nikki would also be able to put
Oh,
up.
yeah, there, that's better. Well, now I see the chat. Oh boy, a lot of questions.
Yep, you're going to be busy with all the questions. Can you answer mine too, Jim, while you could just stay on? No.
Well, I want to hear your presentation, so I'm going to stay on.
Oh, awesome. And I heard most of yours. I'm in clinical. So it was in between just one patient for the afternoon. So, but I think who's got this beautiful picture? It is gorgeous.
That's Jim.
Okay.
Yeah, Jim, can you stop your screen share, please?
I'm sorry, what?
You're still sharing your screen. Now it looks like we might have your home screen. There we go.
Did it stop?
It did. Yep. Thank you so much. Okay. All right. So yeah, Jim, what you can do if you'd like to, if you click on that Q&A box, you'll see the questions that have not been answered. We tried to delete the ones that were answered. It looks like the first one that you could start with would be Danita McGowan at 146, and then everything after that. I'll go through and I'll clean it up if there's anything that's not meant as a question. And you see how to do that. Just type answer, and then you can either type individually to that person or to the whole group.
Okay.
Thank you.
I better get busy.
And you have 3 minutes to do it.
Okay. Oh.
No, I think you have more than that. But then if you're over the 3 minutes, then you have to answer my questions.
That's right.
Just joking. All right. Diane, can you see my screen?
I can. Yeah, thank you.
Okay, perfect. And I believe I sent them to you as well.
Yeah, we have a copy. Thank you.
Oh, no problem. All
We
right.
we put together a pretty lengthy, I think we sent the copy to
It
both
was
of you.
fantastic.
Yeah, so, typically we don't send the PowerPoint presentations out because we
Okay.
do put together such a comprehensive resource book. But if anyone would like a copy of your presentation, I would rather they reach out to you for that rather than disseminate them wholly. Would that be okay?
Yeah, that's absolutely great. And I know some of the resources that Diane I'll be sharing, we actually have housed on the Lamy Center website.
Oh, wonderful.
Yeah, so some of them that might be useful for them. And I know it's a mixed audience. And I'll give a little disclaimer at the beginning just because I know that it's a mixed audience. So
Yeah,
Mhm.
thank you.
That's perfect.
And Dr. Richardson, someone was asking for your contact information. So if you want to go ahead and share that, that's up to you. You can share it individually with that person or with a group, or you don't have to share it all if you don't want to.
Is that in
It was
the
one of the
chat?
questions. Yeah, it was one of the questions.
Okay.
Yeah, you'll see it as you go through. All right, Laura, it's 2:00. Do you want to get started again?
Yes, I certainly will. So I'd like to extend a very warm welcome to Dr. Nicole Brandt. She's a professor in the Department of Practice, Sciences, and Health Outcomes Research, and she's executive director of the Peter Lamy Center on Drug Therapy and Aging at the University of Maryland School of Pharmacy. She's expanded geriatric training opportunities there, including the Geriatrics Palliative Care Pathway, the American Society of Health System Pharmacists accredited geriatrics residency, and a 2-year post-PharmD fellowship. She was named the 2019 recipient of the American Geriatrics Society's Dennis W. Jonigan Memorial Award for her leadership in geriatrics education. She's worked on various interdisciplinary teams across numerous practice settings and is currently leading initiatives to integrate sustainable pharmacist-directed services to help older adults with multiple comorbidities at the MedStar Center for Successful Aging. She's been active in promoting optimal care for older adults and has affected this through her educational, clinical, and healthcare policy work. She co-led an initiative that led the University of Maryland, Baltimore, and University of Maryland, Baltimore County to become the first universities in the state of Maryland to receive the Age-Friendly University distinction. She's directed projects with multiple stakeholders focusing on Medicare Part D medication therapy management, high-risk medications, and medication stewardship. Her public policy advocacy occurs on both a state and national level. She's one of the authors of the American Geriatrics Society Beers criteria for 2012, 15, and 2018 and 19. And she's a past president and board chairman of the American Society of Consultant Pharmacists. She also co-chaired a task force convened by the Peter Lamy Center with assistance from the U.S. Deprescribing Research Network. And that was all about developing an implementation guide for post-acute and long-term care during the COVID-19 pandemic. So we are honored and thrilled that you've joined us today, Nicole. So thank you so much for your presentation and support of our ADRD series.
Awesome. Well, thank you, Laura. And I have to do a thank you to Dr. Richardson, who is one of the teams I worked at in the past. And it's such an honor to be a co-presenter with him. So for those of you who don't know me, Nikki Brandt, I'm humbled by the introduction. And I always say my most important title is I'm a mom of two that keep me very humbled. But I'm excited to talk about a topic that's near and dear to my heart as a pharmacist on the team, which is really looking at medication management and some of the considerations. I know that we have a mixed audience. I'm actually in practice today, so you may see someone walk by at times, but I practice what I preach. So I'm very fortunate to be, as noted by Laura, working over at the MedStar Center for Successful Aging, as well as teaching at the University of Maryland. So if there's terms, questions, please put them in. I'm hopeful there's going to be a lot of discussion. We only have like a half an hour to 45 minutes together. So I've been trying to consolidate some of my thoughts. This is just a little bit about me, but this work really matters to me because dementia, which encompasses, as Dr. Richardson already mentioned, primarily we think of Alzheimer's disease, but other causes of it. And I think that's why it's so important to get a comprehensive workup. And so, as a pharmacist on the team, and any team member for that matter, and you as caregiver providers, I think it's really important to look at all medications. So I broke this down into 3 steps. I figured I had 30 minutes. I can get through 3 steps. And as adult learners, I think it's great to kind of break things into 3. So the first step is really evaluating all medications and evaluating someone's ability to manage their medications. And so, as we know, with Alzheimer's disease in particular, executive dysfunction happens early on in the disease. And we know that medication complexity is building in all patient populations, but especially our older patient populations, not just in the sheer volume of pills that are being taken, but also in the complexity of some of the other regimens. And they may not be pills, inhalers, insulins, and other types of devices. So I've, as Laura mentioned, have worked with the American Geriatric Society and worked on the most recent update that was published last year in May of 2023. And I think it's really important because this particular tool or resource is for all individuals in caring for older adults to really bring attention to medications that might be potentially inappropriate. And I think it's really, really important as we're caring for individuals with cognitive issues to look at those medications. So there's particular call outs within each of these tables. And the American Geriatric Society actually has a forward-facing website for older adults that also can help guide them in terms of having conversations with their doctor about potentially some of these medications. So I'm going to highlight, because we're talking about dementia and cognitive decline and concerns, I'm going to focus a little bit about anticholinergic medications, but I'm also going to focus in on medications that might worsen cognitive function or be associated with dementia. So every 3 years, every 2 to 3 years, there's a group that gets together and pulls the literature and evidence. And through the years, there's been reoccurring recommendations to try to avoid some of these medications. And I can say, working on this through the years, excuse me, is that some of the evidence has gotten even stronger. So we know that some of our first generation antihistamines, which I'll probably need after for my allergies, can be problematic in our older adults because it can worsen and increase the risk of confusion and dementia. So, and this again, are not just prescribed, but over the counter. So I'll show a picture following up regarding some of them. It's also important to note the association with estrogens, with or without progestins, in terms of their implication on cognitive health. Anticholinergics, and there's a lot out there. These could be medicines for mood. It could be medicines for our bladder. It could be medicines for psychiatric conditions, such as we talk about antipsychotics, some of the older generations that, again, can cause an impact on someone's ability to recall things. And again, the increased risk of dementia. There's been an emerging and sustaining literature on the role of benzodiazepines, especially chronic use of benzodiazepines early on, showing an increased incidence or risk of dementia. And those medicines can be used for sleep, anxiety, and sometimes REM sleep disorders. So something to note. And then other agents that are used for sleep, such as our non-benzodiazepines or benzodiazepine receptor agonists, such as favorably called our Z drugs, Ambien or Lunesta. And those also have shown an increased risk of dementia. So I think as we look at medications, and we're going to talk about treatment approaches, it's really prudent to reduce the use of these medications that have been associated with the increased risk of dementia. All right. I'm praying that my voice will hang up for us. So as I mentioned, we know that about 50% or more of our older adults or caregivers don't tell their physicians, like Dr. Richardson, about their over-the-counter medication use. And these are commonly seen medications that could be used for seasonal allergies. They might be being used for sleep. Okay. Or they might be used for pain, also helping with sleep. So as a pharmacist and any member of the team, it's really important to get a good history and to avoid these medications, especially if we're worried about cognition. Chlorpheniramine is another agent that has a lot of anticholinergic properties. And again, this is really important because they could block one of the chemicals in our brain called neurotransmitters that are associated with helping with processing of memories. So it's really important to reduce the use of these medications. So I always say to families, caregivers, and people who care for older adults, these are medications, again, that really to have candid conversations about. We continue to see in those, again, with increased risk of cognitive decline, some of that same kind of carryover. So you'll see this, and this is, again, brought forth in some of the literature, as well as research done with the American Geriatric Society Beers criterion. So in addition to looking at medications that might worsen someone's cognition, it's really important to look at administration. So I kind of alluded to at the beginning that memory can impact our day-to-day functioning, and that's when we get worried and get diagnosed with dementia. And memory changes can lead to people either undertaking their medications or overtaking their medications. And so that's one of my roles on the team, is to look at people's patterns of use on how they're taking their medications. And oftentimes families or others are involved in medication oversight, or they should be. And that's where a candid conversation, kind of like driving the car, but managing the medications, is another safety concern. To further that along, we know that older adults have issues with hearing and vision and potentially dexterity, which can affect their ability to administer their medications or understand directions about their medications. Oftentimes, when the disease progresses and the later stages, dysphagia or dysphagia can occur, which is difficulty swallowing. And so medications might be crushed or cut, or we might be switching them to liquid form. One of the things I would say to everybody in the audience is to always check first, because some medications might be toxic if you're cutting them or crushing them. And then we know that cost, and you're going to hear me talk about some of these newer medications that have been indicated for the mild stages of Alzheimer's disease, can be quite burdensome in terms of cost and have huge cost implications. But many medications that are out there to prevent furthering of underlying conditions, atrial fibrillation, we see patients taking these rather expensive medications like apixaban or Eliquis to prevent strokes from happening. And so those might be a cost issue. And we know that healthy body, healthy mind is critical. So looking at all medications is really important. So I like to say high touch and low tech is often what I see, which is affordable for many of the patients I care for. So making a clear medication schedule, keeping it simple in terms of looking at how many times a day medications could be being taken. But to discuss with providers, especially when your loved one might be taking medicines 3 to 4 times a day, which is a very complex regimen. And that was some of the work that we did during COVID on how to simplify it. There's many devices out there that could be used as a reminder system. I'm not promoting one over the other, but yeah. But bear with me just one second. But I would recommend that you look at your systems and any reminder systems that you're taking to see if it's effective and useful. The other thing I highly recommend, our center is positioned right next to the Poison Control Center. And so this is a number I tell everybody to keep on hand as a family member or caregiver, because medication unintentional overdoses can happen. And the Poison Control Center is 24/7 who can help you with that. It's also a great resource is if there's a medication that you pick up and you're not exactly sure what it is, to check into it. I've seen that happen as well. So the Poison Control Center, and we've done work with them in terms of looking at patterns of medication safety and use and overuse, and older adults are really, really at risk. I'm hopeful that every one of you keeps a medication list for yourself or your loved one. And I think it's really important to understand what the medication is for. And oftentimes I hear from family members or caregivers, I'm not exactly sure why I'm taking this medicine. And that's why it's having that conversation at the front so you can set expectations of what that medication might be helping. It's important to look at how often it's being taken, who's actually prescribing it. And then we all are forgetful at times. So having any concerns noted. Is your loved one becoming more confused after taking these medicines? Are they more sedated? Are they falling more? Are there concerns? So that's where noticing the start of medication is sometimes helpful. The color and shape is just a note there because we know that there's lots of therapeutic exchanges going on, especially with generic medications. So the color and shape may change. But I always say to every patient I care for is always check your medicines before you leave the pharmacy to make sure that you know what they are and that a medication error hasn't happened. So that's kind of step number one. So fixing, I call what's called the low-hanging fruit, avoiding medications that shouldn't be used. And then looking to make sure that we're not causing undue harm by mismanaging medications. So understanding treatment approaches. And so I want to thank one of my colleagues here, actually a couple of them here at MedStar. We did a talk for the Maryland Gerontological Society Association in the fall. So we put some of this work together. We had called that one Setting Expectations. So I'm going to kind of use that same kind of theme. So you heard Dr. Richardson talk about Alzheimer's disease and the progression of Alzheimer's disease, and especially the latter stages. And we've seen with that becomes more functional impairment, more neuropsychiatric symptoms. And I show this slide because in science, we often look at what's called the curve of the progression. And we know with aging that we see some age-related memory impairment. Our processing may be slow. There's some normal decline in the amount of functioning neurons that we have in our brain that can cause normal age-related changes. But what we see in individuals with Alzheimer's disease, both from a neuroimaging perspective, but also from a clinical presentation, is this progression. And so this kind of decline over time. We call that in mathematics a slope. And so I bring that up because as I show you some of the graphs out there looking at these medications, some of them may impact the slope, which may slow the progression of the disease. Others may just be symptomatic management. So I'm going to focus, because again, we don't have a lot of time together, but I'm going to really focus on the FDA-approved medication options for Alzheimer's disease in particular. So I'll spend a little time talking about a medication class, actually, the cholinesterase inhibitors. You may hear them called the acetylcholinesterase inhibitors as well. These medications have been on the market since 1994. We deposit 30 years, 1994. The first one that came to market, I don't even list here, it was called Tacrin or Cognex. I was just starting my pharmacy training at the time. It was a 4 times a day medicine. You ask yourself, 4 times a day on someone with cognitive issues, how can that even be possible? And it also had liver toxicity. So needless to say, in 1997, when I graduated from pharmacy school, donepezil came to market. And donepezil, still to this date, also known as Aricept, is the most commonly prescribed cholinesterase inhibitor. And I put these under what I call symptomatic management, okay? And we'll talk a little bit about some of the symptoms they improve. I like to say the A, B's, and C's of Alzheimer's disease. So A's being there's been some association improving function in terms of activities of daily living. There's been some studies, though limited in terms of their scope, maybe helping out with some of the behaviors. And then C being the cognition. And that's what the FDA approved them on in terms of showing an improvement in some of the cognitive scales that we use in Alzheimer's disease. Another agent is rivastigmine and then galantamine. I put the brand names in parenthetical just to give you some insight in terms of some of the confusion sometimes that happens with some of the names. The class that came around in the early 2000s, I think it was about 2001 to be exact, is memantine or Namenda. And we'll talk a little bit about how that works, but it affects a different chemical in our brain. And then the manufacturers got together and they made Nemzaric, which is a combination of memantine and donepezil, to reduce pill burden, but exponentially increase cost. I know this talk, I'm focusing primarily on Alzheimer's disease in terms of the treatment for the actual disease, but there have been over the last year and a half, 2 years, 2 medications that have been indicated for neuropsychiatric symptoms related to dementia. And I think they're worth mentioning. Not that I'm promoting them, but worth mentioning because the pharmaceutical companies do direct consumer advertising in terms of these now FDA approved indications for use. So brexpiprazole, Rexulti, which is an antipsychotic, has gotten an indication to treat agitation that may be due to Alzheimer's disease. And this medication is a branded medication, which is similar to one of its predecessors, or Aripiprazole or Abilify. But this one is the only antipsychotic to date that has an indication for Alzheimer's disease, and in particular, the agitation. So, but as we know with antipsychotics, and again, I'm not going to spend a thorough conversation about this, but antipsychotics have boxed warnings in terms of the increased signal of mortality in those with Alzheimer's disease and related dementias. And part of that bore out of some of the older antipsychotics, but FDA did put a box warning on the first generation, second generation, and all antipsychotics. Another medication is suvorexant or Belsoma. Belsoma is a medication that has been indicated in terms of helping with sleep. And they've actually, in particular, studied it in individuals with Alzheimer's disease. It's an interesting medication because it actually blocks the orexin receptor. So unlike some of those other agents I talked about, which affect the benzodiazepine receptor, I'm getting a little pharmacologic on you, but it has a different mechanism. So it doesn't seem to have the cognitive implications. But you still have to watch out with this agent in terms of falls, and do have to watch in terms of monitoring that closely. And we need to be mindful of that in our older adults, and especially our older adults with Alzheimer's disease. And then the newest, how we say, class of medications that have gotten a lot of attention, both by the FDA and other pharmaceutical companies and agencies, have been our anti-amyloid beta-directed agents. And these medications are fascinating in the fact that their data is suggesting that it slows disease progression. And so the first medication that came to market that was produced by a company called Biogen. So just in full disclosure, I do not have any affiliations with any of these companies. But I do work on the American Geriatric Society Beers criteria. I say that because I think we all need to be mindful of who's presenting the data and how the data is being presented. I will use some of the data that was shared by the pharmaceutical company, in particular to lecanemab or Leqembi, which is the only anti-amyloid beta-directed antibody currently being prescribed and available. And we'll talk in depth about some of the data and some of the things that you should be mindful of, whether you're a prescriber or you're asking about these medications. And then the most recent one, donanemab, which is produced by Lilly, is still under regulatory review. And that was kind of surprising because I actually had the privilege of being at the International Alzheimer's meeting in Amsterdam, and Lilly launched the medication with its data, which looked a lot similar to lecanemab. And the difference between these two agents is lecanemab, which I'm going to talk about in more depth, is an infusion that has to be given every 2 weeks. Donanemab is an infusion that has to be only given once a month. And I think I've been increasingly sensitized in my over 25 years as a pharmacist is the burden of medications, not just the burden of medications, the burden of monitoring. So we're going to talk a little bit about that. Aducanumab is no longer available as of January 2024. So again, the only medication in this class is lecanemab. So kind of walking us through, so we kind of started with the oldest agents. When we think of cholinesterase inhibitors such as donepezil, galantamine, rivastigmine, we know that these medications are equally effective in terms of their benefit. They are indicated for the mild all the way up to the severe stages of Alzheimer's disease. Some of them have particular indications, such as in the case of rivastigmine, where it is indication for Parkinson's disease dementia as well, and has some of the better studies with Lewy body disease dementia too. The tolerability and safety is something we need to be mindful of. So some of the side effects that are commonly seen when we start off with these medications typically involve our GI tract, our gastrointestinal tract. So some of our patients may experience some nausea, in severe cases vomiting, but more likely is stomach upset and diarrhea. And as we increase the doses of these medications, that side effect can increase as well. There have been in some of our individuals with especially underlying cardiac concerns, syncopal episodes, and you do have to watch for a condition called bradycardia or slowed down heart. So that's something of note, and especially looking at their coexisting medications to see if they're on other medicines that slow down their heart rate. And in some cases, especially if someone's had a recent stomach bleed, you wouldn't want to be putting them on a cholinesterase inhibitor. in some individuals whose breathing isn't well controlled because of the way these medications work, you wouldn't want to put them on a cholinesterase inhibitor. When I think about cholinesterase inhibitors, I think about the ease of dosing. So some of the medications come in different formulations, such as a patch, and that would be your rivastigmine, and now donepezil has a patch. Or it could be a disintegrating tablet that you can place in the mouth. But I show this slide just for the practicality of they're not all dosed equally, both in terms of frequency, but also in terms of formulation. So again, similar efficacy if we get them at their target dose, but it's oftentimes the tolerability and the way they're administered that might be an issue. So something to talk with your providers or your team about. And this shows that, generally speaking, the biggest signal of safety is the adverse effects that we kind of talked about already, but we do see some benefit. The other medication is Namenda or memantine. It comes in two formulations, both in immediate release as well as an extended release. And this medication, if someone has underlying kidney disease, you would have to dose it differently. It wouldn't be a twice-a-day med, only a once-a-day med, and the dose does matter. And memantine can be used in the more moderate to severe stages of the disease. Never did get FDA approval for the mild stages of the disease. And that's because of some of the data. So I just highlighted some of the data here. Again, we can add memantine onto the donepezil to be used in combination and might give us some additional benefit. It doesn't have the GI side effects with it, and it tends to be pretty well tolerated. I have noted sometimes it can improve behaviors, but in some patients it's worsened behaviors. So I think it's important to know the person you're caring for and understand how these medications, that's why I love that note section on that table. So the next class of medications, again, newest to market over the last year and a half, is our monoclonal antibodies. And again, sorry, I'm a pharmacist, so I kind of get excited about thinking about how these medications work and the different stages, because one of the things is we have to have hope. There's hope for the future that we're getting closer in terms of the treatments, and also hopefully slowing down the progression. So we know that by targeting the beta amyloids, and in particular the oligomers, it's critical to slowing down the progression. And there was some previous trials earlier on focusing on the monomers in terms of this beta amyloid formation. But we're seeing that this particular phase, and this is where the clinical trials have had more success. So again, when we think about the findings we see in terms of the scans that we're doing, we look for the plaque and the beta amyloids. And this is where this medication is being targeted. There are some other therapies, and you'll hear me talk towards the end in terms of emerging therapies that are being studied as well to look at the tau protein, which is more associated with the tangles. I'm not going to pretend to get the video working, but there is a video out there, the New England Journal of Medicine, which published kind of the landmark trial that helped lecanemab get its approval. Actually has a brief little video talking about the mechanism and really getting at that protein aggregation. And I think it's important because by using this monoclonal antibody, it's breaking down that protein. But as we're breaking that protein down, may have some unintended side effects that we have to be very mindful of. And so lecanemab is dosed based on weight. So it's important to be monitoring that. And some of the newer formulations like donanemab is not. It's a fixed dosing schedule. So there's some advantages there. I'm so sorry. All right. So again, focusing on the only agent that we currently have that we can prescribe. And it's important to note, setting expectation, that this medication is indicated in patients with mild cognitive impairment or mild dementia stage of the disease, not moderate, not severe. And that's important because there's some confusion when the aducanumab first came to market and how FDA indicated. So, and there's very, very explicit guidelines on how we need to monitor it. So, as mentioned, I am privileged to be a part of a team here over at MedStar and have been working with the committee to look at criteria for use. So many of the health systems out there have been putting criteria for use together to guide prescribers. and the entire team on how best to use these agents. And so, because it's an infusion, and you want someone who's a specialist, there is restricted access to this medication. Because of some of the risk benefits I'm going to talk about, it's important, and not that every program is planning this, but it's important to have a shared decision making. And I know a place that I practiced before, the VA Medical Center, and this particular MUE, or medication utilization guideline, would have them have a signed informed consent on file. So again, they need to meet the criteria for mild cognitive impairment or mild dementia. They have to have an MRI scan within the last 12 months, and I'll talk about the monitoring after they get the medicines. They need to have PET imaging, a FAST score, a cognitive screen. So there needs to be some sort of assessment of function and cognition noted by this specialist. And ideally, you're going to have a neuroradiology team that's going to be consistently monitoring these brain scans to make sure that there's no adverse effects. And that's why it's been increasingly tricky in terms of looking at how this medication is utilized within a healthcare system. So I'm a pharmacist. So the first thing I think of when I think of medications is efficacy and safety. So I'm going to start with safety first. And what we know is, as we talked about, this monoclonal antibody, it's targeting those proteins in the brain. And what we see is that with this medication, we can have this increased risk for what are called amyloid resonance imaging abnormalities. And the E is edema and the H is hemorrhagic. And certain patient populations are at greater risk for having some of these ARIA present. And that's why they recommend genetic testing before you take the infusion to see what kind of risk you're at. And patients that are apolipoprotein allele 4 homozygotes are at the greatest risk for having some of these adverse effects. In addition to some of these neuroimaging abnormalities, which actually could present like stroke-like symptoms, sometimes if there's a lot of cerebral edema, the patient could look like they're having difficulty walking, more confused. So that's something to be noted, not just images on our MRIs. And so I bring that attention because some patients who have gone into a local trauma center or potentially emergency department may have presented looking like they have a stroke, but it was cerebral hemorrhaging occurred after they gave the TPA. So I think there's a lot of education that needs to be done on making sure patients are on these medications, a conversation about sharing that with the healthcare team because of some of the safety signals. Most infusions that we know often have infusion rate adverse effects. So education at the infusion center for both the infusion nursing and the team. So there's some pre-medication treatments that could happen. Again, as we look at this over time, I kind of talked about this already. One of the things I think what's increasingly important to note, and there's been some guidelines that have come out by Dr. Cummings, who's done a lot of work in this space, is concomitant meds such as antiplatelets, which are aspirin and clopidogrel, or anticoagulants such as warfarin or direct oral anticoagulants or heparin products. What we're seeing is that patients, most of the studies allowed aspirin or antiplatelets, but there was only a small study being on anticoagulants. And so there's a lot of safety concern of looking at concomitant meds. And I think that's important, again, to share with the providers in terms of that discussion, because our patients may not just be being treated for Alzheimer's disease. So in order to ensure safety and monitor for some of these abnormal imaging on the brain, MRIs need to be done. So this came out of this appropriate use recommendations. I really like this article. It's been a great review article to position some of the questions. But you can see when I talk about monitoring burden of the medication, is a series of MRIs that have to be done for our patients in terms of to really assess the safety of this medication. So that's something of note. and this is explicit guidelines. So that's a little bit about the safety concerns. And then, of course, we want to look at the cognitive benefit of this medication. So they use the clinical dementia rating scale, the sum of boxes. And the sum of boxes looks at memory, orientation, judgment, problem solving, community affairs, homes and hobbies in terms of functional and personal care. And what they saw is if you compare this over to placebo, you see an improvement. And the change is, about 0.4, excuse me, 0.4 in terms of some of those changes, which when we look at this tool means clinical significance. But I think studies only go out to 18 months. There's been some further studies coming along to look out further, but this is probably the greatest data. There's been some modeling of the data to project out further based on the slope of this line. And that's why they say there's a 27% slowing compared to the placebo, see the separation at 18 months over time, and the improvement over placebo in these domains. I think it's important to note that the CDR and the sum of boxes there's a lot of subjectivity in there, so we need to be mindful of that. A secondary benefit that they did on the scans was to look at the amount of beta amyloid in the brain, which we suspect would go down. And some of the newer agents are also looking at some of the tau pathology, which is the tangles that we talked about. So I highlighted very high level some of the treatment approaches that are out there. But I think what's really prudent is as we talk about medications is to understand the risk and benefits of all medications. How do we monitor their efficacy? How do we monitor their safety? How do we monitor for treatment response? And how do we alert the team if they're having any adverse effects? Again, there's a burden, both in terms of frequency of monitoring, but also in terms of cost. So collaboration is key with family. CMS, coverage. So CMS, the drug was approved, and then CMS, not until July of 2023, then approved covering this medication, lecanemab. And they have this diagnostic criteria that has to be met. In addition to that, there's burden on the prescriber because they have to be registered, the individual, and the prescriber has to participate in this qualifying registry. So I placed in this slide deck the CMS facilitated registry, and then what additional information is needed. So that use criteria that I kind of preempted the discussion with is in part based on the registry's mandatory requirements. And it's really quite fascinating. At least this is my perspective, is looking at this post-marketing mandatory monitoring because our clinical trials for these agents underrepresented Black Americans, Hispanic Americans, in the populations that were studied. And so there's some concerns in other ethnic groups, how effective and safe are these medications. So hopefully through the registry and additional post-marketing surveillance, we'll have a better sense on it. The Alzheimer's Association also has a registry that they've created. And I know that Dr. Richardson talked a little bit about the Alzheimer's Association. I'd be remiss not to kind of share cost with you. And these were based, again, sharing some estimates that we used when we reviewed this for our pharmacy therapeutics formulary. So depending on the weight of the person, the cost will vary. And depending on the type of pharmacy agreement you have. But I think it's important to know not just the cost of the drug, which is anywhere between $18,000 to $25,000, but the cost of the imaging and some of the associated costs for the infusions. So that's why I just wanted to show that depending, it can range anywhere between $60,000 to $64,000 for the cost of this product. And we could have a long conversation about cost of meds, but this is substantial because it's not just the cost of the product, but the cost of the monitoring as well. So the insurance or the companies that produce lecanemab have worked with insurers to see if there's additional support that can be given to help with medication cost. So that's noted here. And so again, when I gave this talk with our social worker, she helped me to kind of navigate that as well. So again, ESI, who's the company that produces it, has some support resources. They also have supporting patients and caregivers during infusions. They put together apps, which I think is fascinating. Wish they would bring down the cost of the drug. But anyways, those are available. The last section that I wanted to bring into the conversation are step 3, which I'll go through quickly to open up for Q&A, is education and engagement. So as you heard Laura mention, we're part of the group working with age-friendly universities, but we think it's really important to talk a little bit about age-friendly health systems, and especially when we're caring for individuals with Alzheimer's disease, understanding what matters and what matters to the families and loved ones that care for them is really important. And so I'm just focusing on the medication M's, but it's really important to think about the interface with their cognition, with their mood, with the risk for delirium, and also some of the risk for falls and the impact it has on mobility. And so we've created brochures to help educate our older adults in our communities. And this is actually a brochure that we put together with the Poison Center to ask questions, all questions, but also talks about how to dispose of medicines. This is publicly available and free of charge. So we recommend, if it can help you, help someone else, please utilize that. And I think it's important, whether we're starting a medicine for Alzheimer's disease or starting a medicine for blood pressure, that you understand why you're taking this medication, the best time to take this medication, how long do I need to be taking this medication? How long before I see benefit from this medication? Is this something that's going to treat something quickly? Or in the case that we talk about with the lecanemab, is going to take, more time before we see a separation from not doing anything? And then what is the goal? Are we hoping to improve cognition? Are we hoping to improve function? Are we hoping to improve behaviors? Hopefully we're hoping to improve all of the above. But if we have a side effect, what do we do? And is there ways that we can prevent that from happening? And that's why I belabor the point regarding knowing the concomitant meds if someone were to start some of these new medications for Alzheimer's disease. It's a journey, and I appreciate that every one of you on this call is in this together, I hope, and hopefully with your team. And I think this is just fascinating to hear about the Alzheimer's plan on a state level. But there's been a lot of recognition to how we can support the team and you as the patient and the caregiver in this journey. And I always like to leave with hope. There's a lot of medications in the pipeline. There's clinical trials that are going on, some of them for cognition, some of them for neuropsychiatric symptoms, which again is a whole nother conversation. But really excited that I'm hopeful that we'll have more treatments in the future that truly slow down the progression of disease. And so a plug to our Alzheimer's Association, as well as the Alzheimer's Foundation of America, and some of the resources that they provide to caregivers and loved ones. So I think I might have gone over a little bit. Sorry, Diane and Laura, but hopefully that gives at least a good background, the 3 approaches to managing meds when you're caring for someone with Alzheimer's disease and other types of dementia. And sorry for my episodic coughing. I still have my voice though.
You were a trooper, and thank you for this fantastic review. I'll go through a few of the questions and try to summarize them.
Okay.
So back to the use of over-the-counter meds.
Mm-hmm.
So if a person is currently using those meds, do you have any tips on how to reduce the use, or should they be stopped completely at one time?
Great question, Laura. So as Dr. Martin knows, this is an area I love to talk about. It's called deprescribing. I don't know, I can't see anybody in the audience, but deprescribing is one of my passions. And it's actually a science to deprescribing. So I never want to tell someone just stop it abruptly, because I don't know the dose. I don't know the indication of what they're using it for. But I think what's imperative is to talk with their healthcare team and hopefully their pharmacists as well, to say, how can I safely deprescribe this medicine? What is a safe alternative if I can't use this medication? And I think that's just really important, because again, if someone's taking 100 milligrams of diphenhydramine, I wouldn't want them just to stop it quickly, right? Even though it's over the counter at 25, I never know how much people are taking. So I think that's what's really important to look at. in terms of those medications. And those could even be the prescribed medications by the doctor. Again, benzodiazepines, for instance, they need to be gradually cut back to avoid what we call adverse drug withdrawal events. And we talk about adverse drug events, but there's this, again, a science to stopping medicines to not have adverse drug withdrawal events.
Thank you. And are you familiar with beta amyloid in the blood? Is there any way to take that out of the blood or research about that?
Beta amyloid's a protein. We talk about it where it deposits in the brain, but there are the protein can be found. I'm not sure about how to remove it in the blood per se. I know there's we worry about cardiac conditions in terms of amyloid, amyloidosis, and there are some therapies behind that, and cardiologists use different treatment approaches. So I'm not sure if they're talking about circulating in the blood or associated with cardiac conditions, but there are some other treatments for that. I focused on the brain.
Thank you. Yes. And Dr. Richardson mentioned about insomnia being, a challenge for a lot of families. Some had a question about melatonin versus a prescription. For them, they were saying melatonin worked really well. Do you have any thoughts on that?
Oh, Laura, it's my go-to. I had the privilege of spending a month over in Europe and as a Fulbright, and I love going to visit pharmacies. I was so excited because they had very low doses of melatonin publicly available. And oftentimes here in the United States, we always think more is better. But when it comes to melatonin, less is better. So typically between 1 to 3 milligrams of melatonin has been studied. And actually what's been fascinating, and when I talk about neuropsychiatric symptoms and sleep and other types of disorders, so melatonin, we do see the underproduction in patients with neurodegenerative illnesses. So, and there are prescription melatonin receptor agonists that can be prescribed as well. But you can start with an over-the-counter. But again, lower is better. And in other countries, they don't allow greater than 10 milligram doses because there is potential for some interactions. So again, lower is better, mindful of that, give it time. The other thing, and I'm sure Dr. Richardson talked about that, is, avoiding devices such as our TV or, and some of these, the lighting that we're getting from them, because that can also affect the release of melatonin.
Yeah. Any thoughts on rapid release? Someone who's listening is explaining that it's usually it's more expensive than regular tablets. Any idea? Are we
talking back to melatonin?
I think just in general about rapid release type drugs, they seem to be more expensive. Is there a good reason for that?
Well, I'm not sure what they're referring to, but it could have been the disintegrating tablets or something like that. I'd have to get context to it. Every drug has different formulations, and every insurance has different formularies. So it makes it a very complex in terms of what the preferred agents are and what's being covered. So memantine, the immediate release, is cheaper than the Namzaric, which is a combination. And we can more than we did in the past get memantine extended release. So I'd have to say it just depends on the formularies and the products, especially if it has a generic or doesn't have a generic.
Okay, and this next question talks about changes in status. A family member has declining kidney values, and she's asking about maybe having a discussion with the neurologist to decrease the dosage. She's a caregiver. She sometimes feels like her concerns or suggestions are not valued. Any thoughts?
Well, I think persistence is key. So to that caregiver, I empower you to be persistent, because there's age-related changes and there's disease-related changes. And a lot of medications are eliminated through the kidneys. And so if someone has an underlying kidney disease, and we've actually seen a lot of concerns with some of the cardiac medications, and some of the, even galantamine has to be renally dosed, memantine has to be renally dosed. And as we know, as we increase those concentrations of meds, it puts us at greater risk for adverse effects. So I would say talk to, I'm not sure I would talk to the neurologist. I'd probably talk to if they're seeing a nephrologist. So we work closely with our nephrology team, especially in some of our patients that advance into end-stage renal disease. What can we get rid of? What can we change? I always like to say to older adults and family members, medications are constantly changing because our bodies are constantly changing. And, I think it is really prudent to get a reevaluation of all of your medicines because of those changes in our body. Some of them are normal aging, some of them are not. And that's why it needs to be individualized.
That's great advice. Another question on Aricept and Leqembi, can they be given at the same time?
So great question, Laura. So in the clinical studies, they did permit patients to be kept on their stable dose of Aricept. So that was because, as you know, Aricept is indicated for the mild stages of dementia as well. So if they were on stable doses, they allowed them to stay on it. I forgot exactly the percentage of concomitant use, but it was fairly substantial.
Okay. Any thoughts on vitamin supplements?
No, that's $1 billion industry, Laura. So there's a lot of conflicting data on vitamin supplements. I think it's imperative that you talk with your healthcare team. We know that some medications that we use chronically, maybe to help with our stomach acid or to help with our diabetes, can reduce B12 levels. And so there's, changes, or if you've had gastric bypass surgery, your absorption of B12 can be affected. So there's definitely literature on the B vitamins. In terms of potentially helping with cognitive health. There's lots of formulations out there, and I won't get into naming them, that have a lot of different vitamins within it. And some may be beneficial, some may not. Oftentimes it's in the earlier stages. But I think the first thing is to treat what's reversible, and such as maybe B12 or vitamin D that we can measure effectively. So those are just some thoughts. I do see a hand raised. I can't believe I've got a hand raised. I feel like I'm in a real classroom now. Hands raised.
How about vascular dementia? I know a lot of these meds are for Alzheimer's disease, but is there any medication for vascular dementia?
Great question. So Laura, none of these medications are indicated for vascular dementia. Doesn't mean that we may not be using them, especially we think it might be mixed disease. But pure vascular dementia, the data, and all of them have gone for indications for vascular dementia, but the FDA did not approve them. But mixed disease, and again, the diagnostic sensitivity in terms of knowing what you're treating. So again, the agents, in particular, the monoclonal antibodies are not being studied, obviously, for vascular dementia. It's just Alzheimer's disease. But the other agents went for FDA approval and they did not get approved, but they could be being used for mixed disease. So I think that's important to note. What's really important with vascular dementia is a lot of lifestyle changes and getting other vascular risk factors under control. So I say to families, there's actually some really interesting emerging study looking at the way we treat high blood pressure in patients who are at risk for cognitive issues. So that's some interesting, we just took a look at that with certain type of class angiotensin receptor blockers, ARBs, they're favorably known, and potentially having more cognitive benefit than some of the other treatments. So so vascular risk reduction, quit smoking, help with obesity. And, I know we can't get into this, but there's even studies going on with the GLP-1As in terms of potentially with cognitive health and vascular health. So, yeah.
Thank you. How about, could you just tell us, are there any clinical trials in the area or in the state of Maryland, and how a person might access those for drugs?
Clinicaltrials.gov. Yes, and there are. We're very fortunate in the state of Maryland to have major research centers that focus on this. Hopkins, MedStar, University. So clinicaltrials.gov will give you some guidance. If you need any assistance there, let me know, but there are definitely clinical trials going on.
Yes, thank you. And the last question is related to multiple sclerosis, MS, related to cognitive disease. Is there any medicines that might treat that?
The key thing is kind of like HIV-associated dementia, multiple sclerosis, is you want to get the disease under control, and then monitoring cognition over time. I think there's just been such an amazing explosion of treatments for MS, and I know some of the secondary benefit might be the cognitive benefit as well. So, but I think as we know, just as caring for individuals with chronic disease such as HIV, we monitor cognition over time, and sometimes those medications can help. So, so I would say that's an emerging science and potentially secondary benefit of those medicines.
Thank you. And just to kind of wrap it up, a comment about daily medication management and how daunting that is under normal circumstances for an average person, and how frightening it could be for an overwhelmed caregiver or an older adult with a cognitive challenge. So any tips for that?
Yeah, I love the KISS philosophy, keep it simple. And that's where having that candid conversation about what are the goals of care, and how can we simplify the medication regimen. It's important, though, if they're having difficulty swallowing, because you would want to go to extended release, but if you're going to crush them, that's going to be a problem. But I think becoming very mindful of both the over-the-counters as well as prescription and the medication volume, and then putting some sort of system in place to oversee that is really important. It's like driving. I treat medications like driving. It's a complex task, and there's a lot of things out there, and people will say, well, I can drive 1 block by myself. And they're like, I've been on these meds forever. I'm like, yeah, but it's when things change, especially when things change, that they don't adapt to those changes well, and get confused. So, especially with some of these high-risk medicines that are out there.
Yeah. Okay, Diane, do we have the post-event survey available?
Yes, and I believe Min has dropped it into the chat box already. Thank you, Dr. Brand and Dr. Richardson. I think you're still on the webinar as well. So thank you both so much for your time this afternoon. Dr. Brand, I'm so happy that your voice lasted. So
I did. I'm so sorry for a few of those coughs, but I cleared the room. The student left. She's like, I'm not staying in here. So anyways, I thank everyone for bearing with me through the coughs, but it was a great conversation. And just like Dr. Richardson, if there's questions that you still have unanswered, Laura, Dr. Martin, let me know. And if people want the slides, more than willing to share.
Perfect.
Thank you.
Thank you.